Welcome to the deep dive. Okay, let's get straight into it. We're doing a high-yield session today, specifically for your revision. It's built directly from those MSRA pediatric notes you shared with us.
That's right.
So our mission really is to take those detailed notes on one specific condition and just turn them into something memorable, a really dynamic deep dive, pulling out all the key facts you need to lock down.
Exactly. Look, revision notes are great, but making them, actionable, easy to recall under pressure, that's the key. So we'll guide you through this stuff, sticking just to the condition in your notes, hitting every section you laid out.
The condition we're tackling today is hypospadias. So
Yeah.
just at its core, like your notes define it, it's a congenital condition, right? Present from birth, where the opening of the urethra isn't at the very tip of the penis. It's somewhere on the underside.
Yeah, and what's pretty striking, right from your notes, is how common it actually is. It's cited around 3 per 1,000 male infants, or what's that, about 18 per 10,000 live births.
Yeah,
That's quite a few.
it is.
Plus, there's a big flag about a genetic link straight away. A 5 to 15% increased risk for male siblings. I mean, that statistic alone tells you quite a bit about potential causes, doesn't it?
Definitely. Okay, so here's the plan for this deep dive. We'll walk through the definition, causes, risk factors, how it physically happens, what else it might look like, how often it occurs specifically in the UK.
How it presents clinically.
Right, the clinical side, how doctors figure it out, the management, prognosis, and, potential problems, all just focused on making this stick for your revision.
Sounds good.
So let's unpack this then, starting with the definition. What exactly is hypospadias, based on your notes?
Well, it's that congenital condition, like you said,
Right.
characterized by the abnormal ventral displacement of the urethral opening. Ventral meaning, on the underside.
Right, underside, not the tip. And just hitting that incidence again, your notes mention it twice around 3 per 1,000 male infants.
Or 18 per 10,000 live births. Yeah.
And how's it usually picked up?
Typically, it's something noticed during those routine newborn checks.
Yeah.
The physical exam. Or sometimes parents might be the ones to flag it. They notice an abnormal urine stream. Maybe it sprays weirdly or doesn't go straight.
Okay, high yield tip for you then. These basics, what it is, where the opening is ventral, when it's usually found, and that frequency, the really fundamental starting points. Need to nail these.
Definitely. Now, let's add a bit more detail. Paint a clearer picture using the key characteristics from your source material.
Okay, so beyond just the opening being in the wrong place, what else should you look for?
Well, the position of that opening can vary quite a bit. Your notes say about 90% are on the glans, so the head of the penis. But others can be much further back, mid-shaft, nostril, even in the scrotum itself. So there's a range.
Right.
And a really key sign highlighted in your notes is the foreskin.
Right.
It's often incomplete on that underside, the ventral side. So it looks kind of hooded on top dorsally, but it's deficient underneath. That hooded prepuce is a major, major clue.
Oh, okay, so it's not just the hole, it's the foreskin appearance too.
Exactly. And often, coupled with that, you see penile curvature, specifically called chordee. Your notes define this as ventral penis curvature, basically, a downward bend. And in the more severe cases, you might also see the scrotum positioned a bit higher.
Okay, think about this for a question then. If you get a clinical scenario describing a newborn, hooded foreskin, downward bend, what diagnosis should pop right into your head?
Hypospadias. That combination is pretty classic.
Got it. Now, your notes also mention associations. What other conditions is hypospadias linked with?
Right, associations. The source explicitly mentions undescended testes in about 10% of cases.
Yeah.
And it also lists cryptorchidism, which is essentially the same thing. Testes hasn't dropped also at 10%.
Okay, so 10% for undescended testes, cryptorchidism.
Yep. And inguinal hernia is also noted as a possible link. So hypospadias can occur alone, but you always need to check for these other things.
Makes sense.
The notes also link incidence to low birth weight. That's another factor.
And as we touched on, for older kids or adults, that main issue becomes the urine stream spring, difficulty aiming.
Memory hook. That 10% figure for undescended testis cryptorchidism. Nice round number, easy to remember, and a common association they test on.
Okay, so we know what it is, what it looks like, but why? Let's get into the etiology of the causes and the risk factors. Your notes suggest it's not just one thing.
That's right. The source clearly states it's a combination. Genetic and environmental factors working together. We mentioned the genetic bit earlier, that 5 to 15% higher risk for brothers. That's a strong hint. It's not just random chance. And specific risk factors highlighted are family history, obviously, but also certain maternal exposures during pregnancy, things like specific meds or hormones.
Hmm.
And interestingly, increased maternal age is also listed.
So it's all about things happening during that critical window of fetal development.
Exactly. Revision focus.
Yeah.
Key takeaway here is understanding its multifactorial genes plus environment and being able to list those specific maternal risk factors. That's high yield for understanding the why.
So biologically, how does it actually happen? The pathophysiology, how does that opening end up in the wrong spot?
The notes give a nice, clear explanation here. It boils down to incomplete development of the urethra while the baby's growing. Normally, these urethral folds fuse up along the underside of the penis, right? Like a zipper closing.
Okay.
In hypospadias, that fusion process just doesn't complete fully. It stops short, leaving the opening somewhere before the tip.
Memory tip. Thinking of it as a failure of completion or incomplete fusion might be helpful. It's not that something formed totally wrong, it just didn't finish the job. That might stick better from the notes.
Right. Now, if you see a child with some of these findings, what else could it be? The differential diagnosis. What conditions might look similar?
Your notes list two main ones, epispadias and concealed penis.
Yeah, and we can kind of use the names, like your notes suggest, to help differentiate. Hypospadias is hypo below, underside opening. Epispadias, epi means above, so the opening is often on the upper, the dorsal side. Totally different location.
And concealed penis.
As the name suggests, it's sort of hidden or buried in the surrounding fat pad or skin. So the penis itself might be normal size, but it looks small externally because it's concealed. Different issue altogether.
Right. Think about this for a question. Baby's penis looks unusual. How do you use the location of the opening, the foreskin, the curvature to tell the difference between hypospadias, epispadias, and concealed penis based on what we've covered from your notes?
That ventral opening, hooded prepuce, maybe chordee, that points strongly to hypospadias.
Okay, let's zoom out again. How common is this specifically in the UK? Your notes give an epidemiology figure,
Yes, UK prevalence is put at approximately 1 in 300 male births.
which lines up pretty well with the earlier 3 per 1,000 figure, right? Just stated slightly differently.
Exactly. 3 per 1,000 is about 1 in 333. So 1 in 300 is in the same ballpark. It reinforces that it's relatively common.
Okay, back to the patient perspective. How does someone with hypospadias actually present? What are the signs and symptoms? The clinical presentation.
The main symptom noted in your source is that abnormal urinary stream. The spraying, maybe difficulty aiming it.
And the signs. Things you'd see on examination.
It's those visible things we've talked about. The urethral opening being on the underside, the ventral aspect, anywhere from near the tip, the glans right back to the scrotum, and often that downward curvature, the chordee.
Diagnostic picture to lock in. That combo of ventral opening A&D, downward curve, chordee, often with that hooded foreskin, that's the classic picture you need to recognize from the notes.
Absolutely.
So once these signs are there, how do doctors confirm it? What are the investigations?
Well, your notes outline the steps. It really starts with a thorough physical examination, just looking carefully.
Assessing the anatomy, locating the opening, checking for chordee, and definitely checking for those associated things like undescended tests.
Yeah, exactly. Then for more complex cases, or if there's maybe a concern about the upper urinary tract, imaging might come in, like an ultrasound perhaps, to get a better look at the urethra and kidneys.
And always checking for those associated issues.
Critically important. Part of the workup is always assessing for those associated abnormalities, cryptorchidism, inguinal hernia. You don't just focus on the hypospadias in isolation.
Revision steps then. Physical exam first. Imaging if needed. And always, always look for associated conditions. That's the sequence.
Perfect. So, diagnosis confirmed, assessment done, what's the plan? Management.
Your notes say referral to specialists is key. A pediatric urologist or surgeon, usually.
That's the first step. And the standard treatment is corrective surgery. And there's a specific timing mentioned in your notes. Surgery is typically done around 12 months of age.
Why then?
Well, it allows for enough penile growth to make the surgery technically easier, but it's before the child gets too mobile, before toilet training, and potentially before any psychological issues around body image start. It's kind of a sweet spot.
That specific age, around 12 months, definitely seems like a key detail from the notes. Now, there was that critical point about pre-surgical care. You highlighted it.
Yes, absolutely vital. Needs bolding in your revision. Circumcision must be avoided before surgical correction. Avoid it.
Why is that so crucial? Remind us again.
Because that foreskin tissue, the bit removed during circumcision, it's often essential material for the surgeon. They use it during the reconstruction to help build the new urethra tube and cover the repair site. If you circumcise beforehand, You've basically thrown away the best building material for the repair.
Wow. Okay, huge takeaway. No circumcision if hypospadias is suspected or confirmed.
Precisely. Your notes also add a good nuance. For very mild, very distal disease, opening really close to the tip surgery might not even be needed. Observation could be enough.
Exam question alert. Scenario. Newborn, suspected distal hypospadias. What's the single most vital piece of immediate advice?
Avoid circumcision.
And if surgery is needed for a more significant case, typical timing.
Around 12 months.
Got it. So looking ahead, what's the usual outcome?
The prognosis. Generally, with good surgery, the prognosis is positive. Most boys achieve, good functional results, peeing, standing up, normal sexual function later, and good cosmetic appearance.
But it's not always straightforward. Your notes mention factors that influence it.
Correct. The long-term outcome isn't guaranteed perfect. It depends on how severe the hypospadias was to begin with, whether there were other associated issues, and, really importantly, how successful the surgery was. Sometimes more than one operation is needed.
Memory note. Prognosis is generally good, but it's conditional. Depends on severity, associations, surgical success.
Exactly. Finally, even after successful initial treatment, what potential problems can pop up later? The complications.
Your notes list quite a few specific issues here.
Yeah, things like urethral strictures, which is a narrowing of the repaired urethra, making urination difficult again. Or fistulas, which are like little abnormal tunnels forming, often from the urethra out to the skin, causing urine leakage from the wrong place. Persistent or recurrent chordee, that curvature coming back. Cosmetic concerns, obviously, the adherence might still be bothersome. And potential psychological or social impacts as the child gets older.
That's a fairly comprehensive list of potential pitfalls.
It is. And because of these potential issues, your notes rightly emphasize that regular long-term monitoring is really essential after treatment to catch and address any complications early.
Revision focus. Definitely be able to list those potential complications, especially the medical ones like strictures and fistulas. High yield for exams.
Absolutely.
Phew. Okay, that was quite the deep dive into hypospadias, wasn't it?
Why?
We've really tried to pull out all the essential bits directly from those revision notes you sent over. Covered everything from definition, incidence, right through to management and those potential long-term complications. Hit the key stats, the clinical picture.
Yeah, and those really need-to-know pearls for revision.
We've flagged things like that 10% association, the surgical timing around 12 months, and that absolute must-remember point about avoiding circumcision beforehand.
Yeah, those are the details that help you apply the knowledge, differentiate things in questions.
So what's the bottom line here? I think it shows that taking structured notes, like the ones you provided, and then actively working through them, breaking them down, pulling out facts, using memory hooks like we tried to do, it's a really powerful way to revise.
Definitely. And it raises maybe one final thought to ponder, building on this. Given that potential for complications and the range in severity in surgical outcomes, how might that long-term follow-up need to be tailored? Depending on the initial case and how the surgery went, it probably needs adapting as they grow into adolescence and adulthood. Something to think about beyond just the immediate pediatric care.
That's a great point. Something to mull over. We really hope this deep dive has been a genuinely valuable tool for your revision process. And if you did find this helpful for your MSRA revision, you might find other resources useful too. Check out passthemsSRA.com.
Yep, and for free revision materials, freemsra.com is definitely worth a look.
Okay, that wraps up this deep dive. Until the next one.